Hi, welcome back to my channel. In this video, I'll be covering the skeletal muscle relaxants. So first of all, we'll go through the classification and then we'll just go through all the important points that are needed for you to know about them for the exam. So first of all, in skeletal muscle relaxants, you have two categories. One is the centrally acting and then you have the peripherally acting. Now in centrally acting, again, you have to remember four basic classes. So first one is the mefesins. Then you have some benzodiazepines. Then you have tizanidine, which is a alpha 2 agonist, okay, and by T you also have to remember thiocolchicide. Then the fourth category is GABA B agonist. Okay, now let's go through peripherally acting. Now in this peripherally acting, just give me a second. So in this peripherally acting, you have to remember that it can be directly acting or it can be indirectly acting. All right, so in peripherally you can have directly and you can have indirectly. In directly you have to remember dantrolene, all right, and you have to remember quinine. Okay, then in indirectly acting we have further two again categories. One is the depolarizing and the second one is non-depolarizing. Now in depolarizing you have to remember, I'll just write it, sorry, so in depolarizing you have to remember succinylcholine, and in non-depolarizing you have to remember two categories again. One is the steroidal and the second category is benzyl isopuinolone derivatives. Okay, now let's go through them. So in first we have mefesins. Now in mefesins, the points that you need to know are these. So first of all, in mefesins you have to know the name. So the first name that you need to know is methacarbamol. Then you have to remember chlorzoxazone, and then important one is carisoprodol. Now here the main thing is that they only inhibit polysynaptic reflexes. Okay, and basically you have to you use them in local muscle spasms, example sprain. Then coming on to benzodiazepines. In benzodiazepines we have diazepam, clonazepam. Now they inhibit both poly and monosynaptic reflexes. Okay, then coming on to the tizanidine, which is the alpha 2 agonist. Now in tizanidine alpha 2 agonist, basically it inhibits the excitatory neurotransmitter. So inhibits the excitatory neurotransmitter. Now in thiocolchicide you have to remember that basically it is basically having an analgesic and an anti-inflammatory action, and it is contraindicated in epilepsy patients. Why? Because it has a pro-convulsant action. Now this is the question that comes, like, which of the skeletal muscles have a pro-convulsant action and is contraindicated in epileptic patients? So that is thiocolchicide. Then in tizanidine alpha 2 agonist, there's this point that it can be used for patients of multiple sclerosis and of spinal injury. Okay, now coming on to the GABA B agonist. Now this is important for exam point of view as well. So in this you have to remember baclofen. So just give me a second. So we have baclofen. I think black is fine. So in this you have to remember baclofen. Now in this baclofen there are a number of points that you should know. So first is that it inhibits both mono plus polysynaptic reflexes. Okay, then it is basically used in basically same thing. It is used in multiple sclerosis patients and spinal injury patients. But the main thing is that it is contraindicated in the cerebral palsy patients. Okay, now coming on to the next one, which is dantrolene. Now this dantrolene, the main mechanism of action of dantrolene is that it inhibits the ryanodine receptor. So in turn it inhibits the calcium release Now indications are spinal injury, multiple sclerosis, and you can also use it in cerebral palsy. Then this is the main question. It's the drug of choice for malignant hyperthermia, malignant and neuroleptic malignant syndrome. And then it has some adverse effects like hepatitis and muscle weakness. Now talking about quinine. Now basically it is indicated for nocturnal leg cramps, and basically decreases the excitability of motor end plates. Okay, now let's talk about the succinylcholine. Now this is the star drug of this class. Okay, so first of all you should know it acts on the NM receptor. Then it basically causes flaccid paralysis. It cannot be reversed by neostigmine. Basically when you are using it for a prolonged time, when used for prolonged time, this block converts into phase 2 block, which is reversed by anticholinesterase. Now one question that they most commonly asked is which muscle relaxant is used during endotracheal intubation. So that is succinylcholine. Okay, because why? Because it gives a rapid onset and a quick recovery. Okay, rapid onset and a quick recovery. Then you also know that it is metabolized, as the name is telling you, by pseudocholinesterase. Now there are some patients who are genetically inclined towards this deficiency of pseudocholinesterase, so in them we see that there is prolonged apnea. Now adverse effects are important. First of all, it causes hyperkalemia in patients with neuromuscular disorders. And basically it will aggravate the mental disorders, muscle disorders, neuromuscular disorders like myasthenia gravis, Guillain-Barré syndrome, and so on. Then it causes an increase in the intraocular pressure, increase in the intracranial pressure, increase in the intragastric pressure. So due to all these reasons, it is contraindicated in head injury. Plus it can also precipitate malignant hyperthermia. If given along halothane. Okay, now let's talk about the steroidal ones. So in the steroidals you have to remember a few classic names, so I'll just write them. So we have pancuronium, then we have rapacuronium, vicuronium, and so on. So basically they have a very little histamine releasing action. They show a vagolytic action because of their action on M2 receptors. Then in this there are certain points about all these that you have to know. So the first one is that this rapacuronium is now basically not used because it causes bronchial constriction, so that's why instead we use a reucronium. Now this reucronium is sometimes used for endotracheal intubation. Then you have gantacurium also. Now this gantacurium is the shortest acting. Alright, now it's the basically first we used rapacuronium. Now this was the fastest acting non-depolarizing skeletal muscle relaxant, but now since we do not use it, so we consider that gantacurium is the one which is now the fastest. Okay, then their metabolism is basically carried out by cysteine. So this you need to know. Metabolism is non-enzymatically carried out, all right, through cysteine. Then we have benzyl isoquinolones. Now in this benzyl isoquinolones, first of all you should know the names. So the first name that you should know is D-tubocurarine, then doxycurium, then atra or cis-atracurium, and we have mivacurium. Alright, now let's understand. Now in all this, you need to know the mechanism of action. So first of all, they release histamine, they block the autonomic ganglia, and they also cause bronchospasm through this action of releasing histamine. Then in this, the things that you should know is that in this, doxycurium is the longest acting. And very important, like most repeated question is this atracurium, it undergoes an Hoffman elimination. Now what is an Hoffman elimination? Basically it is a non-enzymatic process via which the drug molecule undergoes rearrangement and is excreted. Alright, then in this, shortest acting is mivacurium. Shortest acting. Now this has a certain adverse effects also. So in this you have atracurium, which causes which turns into ladonosin, and this causes seizures. Okay, then in D-tubocurarine, it basically causes hypotension. Okay, then after this, I'll just tell you some one-liners for some of them. So in this there is so sometimes now they just ask like some one-liners. So like suppose I'm asking the muscle relaxant which causes you can use in asthma, so that is vercuronium. Then in liver and kidney disease, you can use atracurium because it undergoes Hoffman elimination. Then ETT, I told you, succinylcholine. Alright, then there's this question that often comes is shortest acting skeletal muscle relaxant is succinylcholine, then fastest acting is again succinylcholine. Then if they ask you shortest acting non-depolarizing skeletal muscle relaxant, then you will say mivacurium. If they ask you fastest acting non-depolarizing skeletal muscle relaxant, you will say rapacurium. But now reucronium, but now it's not used because it causes bronchial constriction. Then you use reucronium. If they ask you longest acting and most potent, then you will use doxycurium. And if they ask you least potent, so that is galamine. Okay. Then there's this thing in non-depolarizing skeletal muscle relaxants, you use neostimulant to basically get them reverse the effect. Alright, then there's this one thing that you need to know about is, which is the highlight of this particular lecture. So that is Shugama Dex. Now this is the first selective relaxant binding agent. Basically it is a modified gamma cyclodextrin. It is used to reverse neuromuscular blockade by reucronium. Basically it encapsulates it and blocks the action to neuromuscular receptor at NMJ. Then it is also can be used in vucuronium and pancuronium induced muscle relaxation. Then it is ineffective in succinylcholine and benzyl isoquinolone derivatives. Basically, why is Shugamadex more preferable than neostimulant to reverse the blockade is it is reliable and there is rapid reversal without any autonomic instability. Okay, and this thing also, this workuronium is contraindicated in, just wait, yeah, this you need to know, it is contraindicated in hepatic and biliary obstruction. Okay, so all of this is important for the skeletal muscle relaxants. So if you found this video helpful, do give it a like, share, subscribe. Thanks for